CataractCoach.com, podcast series, episode number 93 with Dr. Bruno Trindade, how surgical teaching videos compress the learning curve and make us better surgeons. Welcome back to our Cataract Coach podcast. Today, I have a very special guest, my dear friend and colleague from Belo Horizonte, Brazil, and that's Dr. Bruno Trindade. Welcome, Bruno, to our podcast.
Thank you so much, Uday, for this very kind invitation and for pronouncing a perfect mineirês. It's the way we say here in Belo Horizonte. Thank you.
Yeah, that's the tough part with the Portuguese in Brazil is it's written differently than it's said. So for a foreigner like me, it took a little bit of time.
But you have a natural talent for that.
Well, we try. I think knowing a little bit of Spanish helps me too. Now, we just came back from a meeting you had, which was amazing. You had an incredible video-based meeting. Tell us all about this. I saw some incredible videos, which we'll get to. Tell me about your meeting. How'd you get the idea?
Well, you know, Uday, I think over the years, we have been very blessed by the amount of learning that we can take through videos. Right. I am a strong proponent of video, of using video as a learning and as a teaching tool. And you know that we have this big teaching hospital with the residents, and the amount of work they are on every single day is just massive, right? And there's every other patient that sometimes the patient just doesn't make sense. Right. It can either be because of something that you did differently that turned out to be exactly the same as what you used to do, or it can be the other way around, something that you did exactly the way you normally used to do, and it turned out to be to produce a very different outcome. And I think those are the very best teaching moments. Those are the very best teaching cases in which it needs to spark on us this feeling of digging deeper into understanding of on what happened differently on those patients, and thinking of this, and also the power of video and the capability of video as a tool for education. So we merged together and put up this meeting, and it is something that we are very happy to host every year with our residents, fellows, and colleagues from around our state. And again, this year we had the privilege of having you here with us, delivering a very incredible lecture. So that's probably the idea of the festival. It's based on on those film festivals that we all know, on the major meetings that we have around the world. But we made a little bit of twists on that, and I think it has proven to be a fine recipe, and people tend to be very interested in it.
Yeah, it's a fantastic meeting. I mean, I learned so much. We can talk about some of the amazing cases that we saw at the meeting, which is really amazing. Tell us the name of the meeting. I'm going to put a link down below. So if you want to, as my listener or viewer, want to see some of these amazing videos, you can go right to the link and find it. What's the name? And then I'll put the link.
Yeah, so we call it the IOCM Film Festival. IOCM is our institute of I Institute here, and it's the hospital that we have our teaching program.
Yeah, so like me, or I used to do, you do both academics and teaching residents and fellows in a big, large public hospital, but you also have a private clinic. You have both.
Absolutely, and I find that to be actually a key element of my practice, because I think I would not be as happy as I am doing neither of those by itself. Right. So I think both public and private, they have their own challenges, they have their own particularities, and you can learn a lot from both practices. And I think the balance between doing both of these, being in both of these environments, it teaches you a lot and it keeps you motivated to keep going. And I feel I'm very blessed to be able to do both of these.
Right, especially being around the young resident fellows, I think it keeps you young. Their level of
Yeah,
enthusiasm, it's
yeah.
amazing.
Yeah, I'm part of a big group. So our hospital is one of the major ones in the country and in the States. And I'm really proud of our residents and fellows and the entire team that work together with us. And as you said, being next to these younger doctors, they challenge you every single day, right? And they keep you fresh. I think it's a great opportunity to be around them.
For sure. What I'm most impressed about with the young surgeons, the next generation, is that they can learn so much faster than I ever did. They can, because they have access to all these videos, they can compress their learning curve. So I tell them, what you learned in 1 year would have taken me 10 years because I'd have to experience the complication. You can just see it on a video.
Absolutely. And I think for that, we need to acknowledge and thank you for being such a passionate and diligent educator and mentor to all of us with your daily videos and your CataractCoach.com website, and now more recently with your podcast. I'm a true passionate about your work, and I think we all need to thank you and acknowledge all the effort that you've been putting into this.
Yeah, we all learn together. In fact, we should
Yeah.
give the most gratitude to the godfather of cataract surgery videos, which is Dr. Bobby Osher. I mean, he's the godfather.
Absolutely. I think he was a pioneer on his generation, and he changed. It was a paradigm shift when he started his video journal back then, 40 years ago, and showing difficult cases and complications, and again things that did not go as planned. And as you very brilliantly said, it just shortcuts the learning curve.
It does. It does.
Yeah.
It exposes you to new techniques or technologies that you may never otherwise see. Like I still remember back in the late 1990s when I borrowed a VHS tape of Osher's video journal of cataract surgery, and I saw Dr. Nagahara from Japan doing phaco chop, and I just couldn't believe
Yeah.
it. I couldn't believe
Yeah.
it. So it was just like, no one at my university did that at all.
Yeah, I think over the years he has taught with that tool, with videos,
Yeah.
so many ophthalmologists around the world that I don't think he even knows or considers how much of an influence he has been to all of us, right? I think I can say this. I can speak on behalf of all the ophthalmology community around the world. I think we have all been influenced by his work and by his videos over the years.
Right. Another thing I really enjoyed in your film festival was you had videos from all subspecialties of ophthalmology. In fact, one of my favorite videos, believe it or not, was a strabismus video.
Yeah, I mean that video was amazing, right? And I think the idea, again, the idea of this film festival is being in a teaching environment. We are exposed to all these different patients, and not only cataract, not only cornea, not only refractive, and not only surgical. It can also be a clinical case, a case of difficult management of a particular patient. And I think the what we uh, what we try to achieve is to motivate the young residents and fellows to keep an open mind, to try to understand every single patient as a unique patient, as someone who deserves your full attention, and not just turn on your autopilot and keep seeing patients as we tend to normally do over time.
Yeah, that's such a critical point. And sometimes this is lost on more novice surgeons. In fact, one of the videos that won in a category was comparing driving while texting on your phone to surgery. While you're doing surgery, you're not really paying attention. You're chit-chatting with the staff about their day. You're singing along to some song music on the radio, and then some bad complication happens. And I thought that was such an apt comparison.
Yeah, and not only I think that was a brilliant video by Isadora. She won the grand prize of our film festival, and she was very talented in showcasing the importance of focus during everything you do. But basically, we're talking about surgery. So whenever you're doing this 5-10 minute procedure, that for you can be just another one in your entire list, but for that particular patient, it's a lifetime moment of their own. So I think they deserve our full attention and they deserve our full focus. And I think what the video tried to show is that we have a big responsibility on our hands, and we need to pay full attention to whatever we do when we are operating on someone. So I think it was a very neat video, and I also learned a lot from it.
Right. And that video will be on that website, which we'll link down below. And so let's go back briefly to the strabismus video. It was an adult strabismus case where this woman who's incredibly myopic, very, very long axial lengths, probably more than 30 millimeters, had the most extreme esotropia I've ever seen in my entire life. The eyes were so esotropic and buried in the nasal canthus that you could only see a part of the corneal iris.
Yeah, and the temporal limbus, right? You can barely see the temporal limbus for both eyes.
Right. The eyes were so nasally deviated that in both eyes, all you could see was a little bit of the temporal limbus. That's it.
Yep. Yeah. So wild. And again, I think the video you'll be able to find in our website once you upload it. But it's a video that highlights this case and the management of this very challenging case with all the new technique of muscle rearrangement, very complex muscle rearrangement. Again, I'm not a I'm not a strabismus specialist, but I can find I can find the beauty of the surgery and the care for that particular patient. I think it was an amazing video too.
Yeah, I mean, the bottom line is when the axial lengths were that long, the sclera is incredibly thin.
Super thin, paper thin.
It looked like paper. You could see through the sclera. And so how do you suture to it? So the surgeons did something very brilliant. I'll tell my viewers and listeners a little bit, but you got to watch the video.
Yeah.
Basically took the lateral rectus, threaded it, intertwined it with the superior rectus, and then reattached it to the stub of the lateral rectus. And this was able to accomplish a miraculous thing. The patient looked like she had almost straight eyes. I just thought after that, all you have to do is make her pseudophakic, make one eye plane, the other eye -3, and then there'll be no diplopia at all because you separated the eyes. Amazing result. I just couldn't believe. I've never seen that before. So I agree. That one definitely should have won. And again, the link's going to be below. You definitely have to watch this video.
Yeah. And I mean, and all the other videos were great as well. But I think what truly surprises me is the capacity, the ability that our young residents and fellows they have to come up with these very unique and teaching videos. So it's an amazing achievement of them.
Right. Another thing I really enjoyed was there was a video where someone showed that you prepare all your own DMEC grafts. So you get the full cornea and you do all the preparations. You show the videos of this, and here are the steps that tend to be an issue. And I just thought to myself, wait a minute, for you to have a video of these issues, it means you recorded, you videoed every time you prepped or prepared a DMEC graft. And I think that really hammers home the point that if you don't record every case, when something happens, you won't have the video. You can't predict when it'll happen.
Absolutely. You never know when complications will come up. You never know which case will end the way you're planning to do. So you know the importance of recording every case. I do too. I record every single case that I have. These days, this is so easy to be done.
Right.
And I think there is a reasonable excuse for not doing this for every single case you do surgery on.
Right. You may not keep the video. Maybe like your dash
Sure.
cam in your car, it just keeps recording over. But when you finally get something, you're like, wow, I got to save that video.
Yep.
And
There has been a lot more than once when at the end of the case, I was puzzled of something that happened that I didn't have an answer for it. Some sort of not necessarily a complication, but sometimes a very dynamic situation that you didn't understand properly of what you said, what just happened, and then you just rewind the video and just watch it again and learn what happened, and then you can keep going, you can move on and probably provide a better care of a patient. So I think it's absolutely mandatory these days to record every single case you do.
right. I mean, complications happen, but what's the difference between a mistake and a lesson? Well, you learn from the lesson. So if you have the video,
Exactly.
you can go back and see, okay, what exactly happened? And how can I learn from this? And how can I become a better surgeon? Then I think it served you well.
Absolutely, and then you can make different mistakes, but not
Right.
that one once again, right?
Right.
Try to avoid that specific mistake on someone else's eye. So I think that's how we all learn, and we need to be attentive to details and attentive to these situations and learn from them.
Yeah, no, for sure. I ended my lecture with a video of me operating where I put in a CTR, capsular retention ring, and I just didn't know what happened. And the capsule starts to get wrinkled, and I'm just very panicked. And then I take the CTR out, and then I ask the audience, well, okay, I don't know what happened. There's the video. You just saw it. You tell me. And I got 10 different answers. So sometimes
And again, sometimes that happens too. You have the
right.
video, you watch it over and over again, and there's not a single answer. That's we're all puzzled by all these situations. So I'm really glad you recorded that video and you're showing this video, because it's truly a unique situation. I think I don't
Yeah.
have an answer for that case.
Yeah, I
No.
don't either. But that's a good point for Osher, right? Osher's kind of the pioneer of bringing out complications. Before he started showing his videos at all the meetings decades ago, they'd only show their best cherry-picked case. Out of 100 cases, they find their very best one, they'll show that one. He will do the opposite.
Yep.
He will show you his complications, because I think
Yeah.
we learn more from complications. Even I encourage people who submit videos to Cataract Coach, which you can do at CataractCoach.com. There's a link that says submit your video. I would love to have more complication videos, because that's how we learn.
Yeah, and the beauty of this is that you can learn from someone else's complication, right? It
Right.
doesn't have to be your own. So I think the more you see, the more you learn, and that will make you definitely a better surgeon.
Right. You sent me a great video, which we're going to show the day after your podcast. You sent me 2 videos. I'm going to show them both, one on the Monday, one on the Tuesday. But one of them was a patient who had cataract surgery and then a DMEC, and it looked okay initially, but then there was some sort of mystery. Why did the graft kind of partially become detached? And the answer is, I won't tell you. You got to watch the video. but it was something I just didn't even think of. And I was like, oh, that makes so much sense. And then you fixed it and you're back to normal. So again, I don't want to give it away. You got to watch the video because it's going to be one of those cataract quizzes. Why did this happen? And see if you can figure it out. And then the second video, Sam, which I really enjoyed, was you called it Everything Everywhere All at Once. Tell me about that video.
Well, that's a very neat case as well. And it was one of those patients that come in with a complication of problems. So it's not only one, but a few problems all combined, degrading her visual system. So basically, this is a lady that has that was submitted that had RK done in the past, and AK cuts that led her cornea to be very irregular. And also more recently, she's developed a cataract, a visually significant cataract, and also she has Fuchs corneal endothelial dystrophy. And to worsen all this situation, her pupils were very large as well. So all that aberrated cornea was distorting her vision, coupled with the endothelium scattering light, and also her cataract. So she had very poor vision in both eyes. So after considering all the options, we decided together with the patients that we would try to fix everything all at once. So basically, what we did, we used we did phaco emulsification to take care of the cataract, and then we used a very high seal toric IOL to correct for the regular components of her corneal astigmatism. And then after that, we used the extra focus intraocular pinhole, which is something that we may be able to talk a little bit after this. It's a supplementary intraocular pinhole that's used to address irregular corneal astigmatism. So it's not a lens, it's just a diaphragm with a 1.3 millimeter central opening. So we implanted that on top of the toric IOL. And also, there's a fourth procedure. We did her decimate stripping only procedure. So a central decimeter axis to read her cornea of her central guttae. So the very first few days after surgery, this patient obviously had a marked corneal central edema, and her vision was not good. But as time went by, and we were using ROC inhibitor drops to facilitate endothelial cell migration. So as time went by, her endothelium started to migrate to her central cornea. And then all of a sudden, on one of her visits, it seems like a magic had occurred. Her cornea was completely clear, and she was seeing fantastically well. So it's one of those cases that you're never sure whether or not you did the right thing until you see the final results.
Right.
And I think at the end of it, we were blessed to have chosen this combination of procedures that provided her an unparalleled vision. She says that she doesn't remember seeing this well in her entire life.
Oh,
so that's basically the case. Yeah.
So tell me about the extra focus implant. So it's something that I was really impressed with. I think your brother won the ASCRS grand prize, the film festival, for this. Tell me all about it.
Yeah. So I like you come from a family of doctors. My dad is an ophthalmologist, and I consider myself very blessed to come from a family like I have. So my brother is I always say he's the smart half of the family, and the creative, definitely the creative star of the family. And it's been around now probably almost 15 years ago where he had this idea of using a small aperture implant to use inside someone's eyes to not only to extend depth of focus, but also to kill corneal aberrations. So
Right.
as you know, the larger the aperture of an optical system, the more the peripheral aberrated rays play a role. So, and again, as in a perfect optical system, you want a very large opening because the larger the opening, the more light you're going to get in. So that will make a better image quality. However, when we're dealing with irregular lenses, in our case, an irregular cornea, the idea is just the opposite. So you want to have a very small aperture to avoid all those aberrated rays that come from the peripheral cornea. And by limiting the light entrance to a single, to a more central point, you get a much clearer vision.
Mm-hmm.
And he came up with this very ingenious solution that is not a lens. Sometimes we call it a lens, but it's not a lens. It's a diaphragm. It has no dioptric power. It's just an occluding mask, black occluding mask with a central opening of 1.3 millimeters. And
That's placed in front of the eye well.
correct. And that implant is to be used in pseudophakic eyes. And it
Right.
was originally designed to be used in the ciliary sulcus of pseudophakic eyes. However, in our more recent cases, whenever we do implantation of the extra focus in combination with cataract surgery, we tend to use it together with the primary lens inside the capsular bag. That may raise an issue on someone concerning of interlenticular opacification because you're using two implants. And this is, again, this is a hydrophobic acrylic implant, the extra focus. And especially using another hydrophobic lens in the bag, that may raise an issue of interlenticular opacification between these two implants. But in our series, and we've been following these patients for up to 10 years now, we have seen 0 cases of interlenticular membrane formation. And the reason for that are two. Basically, the extra focus has a concave posterior aspect that vaults over the primary lens. And secondly, the central pinhole is an opening that allows aqueous humor to flow through it and into the interface. So we're very confident that the interlenticular opacification is not an issue on this particular implant. But this has been a really game changer on these very complex patients, because these patients are usually without any other possibility of treatment other than a corneal graft, right? And the beauty, when we do corneal surgery, when you see great results with posterior lamellar corneal surgeries like DSEC, that doesn't necessarily translate to the more anterior or full thickness corneal grafts, right? We have all seen patients that have had those very pristine, clear grafts that have no useful vision out of it because of high anisometropia and irregular corneas as well. Yes, so we feel that this small aperture approach is extremely beneficial to these patients, to a very select group of these patients. And they can have a very life-changing moments when we use these implants on them.
Yeah, now there's a question that I had, and I'm sure some of my listeners have the same question. Okay, so you've got this black diaphragm that's blocking all the light except the central 1.3 millimeters. Well, how do I examine the retina? And I couldn't believe the answer you came up with, which is brilliant. Tell us, how do I check the retina?
Yeah, so again, that's another Claudio's moment of brilliancy. And so he realizes that this German company, Morcher, has this material that if you look using regular visible light, it is completely black and you can't see anything through it. However, if you use an infrared light, the material becomes completely transparent to it. So, as you know, our OCT machines and many other machines, they operate using infrared light. And because of that, the implant becomes completely transparent and the
Wow.
machine can see your retina very, very easily. That does not equal I don't want to sound as if it is super easy to see the retina in these patients. It is not. It's definitely compromised when you use a small aperture implant. It is definitely harder to see the retina of these patients, but you need to understand that these are usually very thick eyes, and
Right.
the alternative for these for these patients is also not very attractive.
Right. No
So
useful vision. Right.
exactly. So you need to balance the risks and benefits of this technique, but you can definitely see the fundus using infrared equipment. And if you use those wide field lenses and by modifying gaze of the patient, you can see a considerable range of his retina using these equipments.
Yeah, fantastic. Yeah. So congrats to Claudia for winning that grand prize winner at the ASCRS Video Film Festival. But the video thing, that's in your family's blood. Your dad also has won a couple of grand prizes at the ASCRS Film Festival for videos.
Yes, yeah. This has been going on for quite some time now. My dad won his first grand prize in ASCRS in the year 2000. And as a matter of fact, this year I was fortunate to win not the grand prize, but an award in the ASRS Film Festival in the same city in Boston. For the last 24 years, I think our family has been devoted to film producing and has been very, very fortunate to have won some awards as well. So yes, my dad has his own collection of awards, very prolific collection of awards, and he has definitely inspired myself and my brother Claudio to keep going and keep producing video. And again, we need to acknowledge Bob Osher
For sure.
for his work in video as well. I think his award collection is unbelievable, right?
You
You
should
you 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 saw it. It's
yeah.
something that's it's unfathomable.
Yeah, it's rooms and rooms full of just awards and plaques and trophies and
Yeah,
unbelievable. So obviously he has an incredible passion for teaching. And he also
correct.
he's spent the last 40 years basically traveling every month to new countries.
Yeah, yeah, like you, right? I
You know,
think
this has been a world premiere for me.
you're also amazing.
This is, yeah, next year I hope to travel a little bit less. This year was a little, like I haven't been home. This is the first weekend I'm home in the last 10 weekends. So
Well,
it's,
we have our meeting here in Brazil, the Brasfis meeting. It's a big meeting, and it's one that I think I can say on behalf of our society that we have been working very hard to put up a nice meeting, not only for Brazilians but for every friend and colleague that comes from abroad. And you again have been a tremendous partner of our society and have been here for a few times, and we look forward to having you here again next year,
Yes, for
hopefully.
any of my colleagues who are listening, you're welcome to join
Yeah.
this meeting. It's a fantastic meeting. Great learning. There is simultaneous translation, so even if you don't speak Brazilian Portuguese, you can understand everything. And it's going to be in Sao Paulo coming up in May of 2025. And they also have a tremendous amount of live surgery. Now, I really enjoyed watching the live surgery, but that's not too many meetings left with two live surgery events.
Yeah, and I think Brester's live surgery has been a major session in our meeting with numerous live surgeries, with not only routine cataracts, but also complex
Yeah.
cases with amazing surgeons from around the world. So I definitely invite all of you that can't come to São Paulo to join us there.
Yeah. Oh, it's a fantastic meeting. So I look forward to coming back in Sao Paulo in May, and we'll all learn together. Plus,
Yeah.
for my American friends, let me tell you, the food is unbelievable. So when you visit, it is not like anything. You've never had this kind of food before, especially if you like a good steak, picanha. Wow, wow, wow. That is just amazing.
Yeah.
It's a cut of beef that and a way of cooking you just don't find anywhere else. So
Yeah, I
definitely,
think we're lucky to have that here.
yeah, definitely worth considering. So yeah, we'll check out your video link down below for all these videos. I think it's a great way of learning to compress that learning curve. Now, tell me, what are the other challenges you see facing your residents, your teaching hospital now? I had an ability to tour your hospital, which is amazing. It's a large facility. You've got, gosh, maybe 40 something residents. You've got a couple dozen or 2 dozen fellows, and your clinic is doing more than 1,000 patients a day. So you're a busy place.
Yeah, it's absolutely. As I said, it's the biggest hospital in our state, and it's one of those things that every now and then you're facing a new challenges, right?
Right.
So I was, as I told you when you're here, I was invited to be medical director of this big hospital in the beginning of this year, and it's one of those things that you're not trained for that, right? And
Right.
it's one of those moments that you're faced with an unknown situation in an unknown environment that you have to learn. So um, ever since that moment, I have been finding myself into unknown terrains, but it has been a very pleasant journey to learn all those admin work regarding a big hospital management. Of course, I don't do this by myself. I have a whole very talented team together with me, but it is interesting to be challenged by this as well.
Yeah, it's a big facility. So, I mean, it's bigger than any USA teaching hospital I've been to. I mean, it literally is more than 1,000 ophthalmology patients seen per day. So
Today, yes.
it's
Yeah,
unbelievable.
it's and again, as I said, we're very proud of our team of residents, of our team of fellows, of our team of preceptors, of staff. Uh, Everyone tries to do their very best job in providing patient care. I think that the excellence is on the DNA of our institution. So we strive to be as good as we possibly can in providing patient care and providing the best care that these patients can have. And it is a 100% public hospital. So we take care of patients who are mostly in need,
Sure.
and they come to our hospital to have that sort of care. So we're very happy to be part of this group, and we're very proud of all the people involved in this project.
Yeah, the patients are very fortunate because they get world-class faculty, enthusiastic, hardworking residents and fellows, and cutting edge technology and care. Like, I mean, you have a corneal problem, you can get a DMEC graft. It's done. So whatever you need, they can get anything done. And your facility does the entirety of ophthalmology. So from oculoplastics and orbit to strabismus to cataract, refractive, glaucoma, retina, everything.
Yeah, everything. Yeah, true, true. Again, the fellows and residents are the ones to take credit of this, because they do the hard lifting here.
Yeah.
They're the ones who do the hard work.
But they learn, the best part is they're learning, okay, in the evening they go home, they may read their books, their ophthalmology books. But when they come to work in the day, they're learning it by doing it with their hands. That's the neatest part.
Correct. Yeah, yeah, and they have a very large exposure to all these challenging cases as well.
Yeah, it was fantastic. I just love the way you ran it. It just kind of it made me so happy to see that the young doctors learning so much and just so involved in this, and they're so enthusiastic. It's just,
I mean, you have done this yourself, right?
at a
So
much smaller
I
scale.
think, yeah,
Much
but you know the challenges of it, and you know the benefits of doing this as well. So I guess that we connect when we
right.
see things that we are passionate about, and that we know about, right?
Yeah. Let me ask you, kind of switching gears here a little bit. We talked
Yeah,
about your case where you did DSO, decimate stripping only, a
yeah.
small, let's say 4 millimeter descemetorrhexis, and then you get migration of the endothelial cells. How do you decide whether to do DSO, which I've never done, or a DMEC, which I've done a few of? How do you
Yeah,
decide?
I guess that's a tough question, and the answer for that is probably unknown for most of us. It's always a balance that you have to weigh between being more aggressive and doing a graft that gives you faster rehabilitation, or being less aggressive and doing a procedure that may be enough for your case and may lead to a proper a clear cornea at the end, but there's also always the risk of it not working as planned, and then you'll have to do a DMAC as a rescue procedure. So I find that it is a very small number of patients that may benefit from this procedure. Usually, the best cases are the ones with a very condensed corneal gutte in the center of a cornea, but with a nice endothelial mosaic at the periphery, because you need those peripheral endothelial cells healthy enough in order
Sure.
to migrate towards the center of the cornea. So, um, uh, as you start doing these procedures, both DSO and DMAC, I think you get the hang of which patient may benefit the best from each of them, but I don't think there's a very clear cut line to go from one to the other. I think that there's a very broad gray zone that you never know which one will be better for a specific patient.
I mean, I suppose in a stepwise manner, you can always start with a DSO if you think it's appropriate. And if that doesn't pan out, you can always
Uh,
take them
uh,
back and do DMAC.
yeah, I think as long as patient understands what's going on, and what the steps are, I think you're probably fine doing that too.
So it seems like now we used to think of our subspecialties as kind of separate. Cornea, here's glaucoma on this side, here's cataract, here's refractive. But they're all kind of moving together, right?
Yeah,
So,
yeah. Yeah, I think the optics of the eye is what is being considered as a holistic treatment, right? So we need to take care of how the eye's optics work, and how we can optimize it with all these different procedures that we have available these days. Yes, I think you're absolutely right.
yeah, I think I think we should kind of split it like, okay, anterior segment surgeons and kind of posterior segment surgeons. So I don't think that someone like me needs to learn how to do a vitrectomy, parts plane of vitrectomy. That's not my cup of tea. I'll give away the scleral buckles too. Let the retina specialist do all that. But to do anterior segment things, I mean, you have to be versed enough. Like the case you talked about, you're everything, everywhere, all at once. You're doing corneal work. You're doing the eye cataract surgery with the IOL. You're doing the pinhole implant too. You kind of have to understand the whole anterior segment of the eye. And listen, if that patient also had some glaucoma issues, you could put in a MIGS procedure. A standard MIGS procedure. So I think it's, in fact, if you look at the Cataract Coach logo now, it's been changed. It's still the same logo, but at the bottom it says cataract, glaucoma, cornea, and refractive. Because if you look at Cataract Coach now, I've got hundreds of glaucoma.
You're combining everything,
I think you have to know. I think you can't just look at one specialty or subspecialty in a bubble. It's kind of all together.
I agree. Yeah, I think, and I think we have seen a tremendous development in cataract surgery over the probably past 4 decades, maybe.
Right.
And more recently, we are probably witnessing the same sort of paradigm shift that we've seen in cataract surgery that is now happening in cornea surgery. So all these lamellar grafts and all these procedures that we do now in the cornea, I think they have proven to be such a tremendous evolution of the what was then the standard of care in the past. So I think that the combination of all these different procedures, and also now more recently MIGS surgery as well in glaucoma. So I think again, as you said, they are all converging to a unique anterior segment surgeon, right? So that will be able to take care of all these problems.
Yeah, for our young listeners who may not know, 20 years ago, when you had Fuchs dystrophy, they treated it with a full thickness penetrating keratoplasty. Like, you would never even think of doing that now. Why do all that? It makes no sense.
Right.
So and then where are we going in the future? Now people are developing these endothelial cells where you just inject them in the anterior chamber, put the patient face down for a couple hours, and next thing you know, you're done.
Exactly.
You heard of these things? Where do you think that's going? Where are we with that?
Well, I mean, as I said, I think we're witnessing a tremendous advancement in our specialty, and I think we haven't reached the end of it, right? Professor Kinoshiro's work has been a full another one of those life-changing moments and like career-defining moments that you can definitely foresee some major changes in which in the way we treat patients with endothelial dysfunction, right? So I can definitely see this becoming more and more available globally, and patients will be the ones who will be benefited by these changes.
Right, because sometimes in the US, we're spoiled, or even Brazil, it's relatively easy for you to get corneal tissue. I mean, your residents were preparing from the full donor cornea, the DMAC grafts. I'm so spoiled here in the US. If I want a DMAC graft, I order it. It comes the exact size I want, the thickness I like, already stamped for orientation, already stamped with trypan blue. It's already done. It's already in the injector. All I get is put it in the eye. But some other parts of the world, though, getting tissue like that, it's almost impossible.
Impossible, right? Yeah.
And so to have something
I mean, it's obviously getting tissue, period, is almost impossible in some parts of the world, right? So I guess we're still fortunate enough to have tissues available for us. Yes, we're not in that. We don't have that amount of comfort that you have to get our tissues detached, pre-stained, preloaded. We need to do ourselves, but still we need to acknowledge that we are fortunate enough to even get access to these tissues, because there are some parts of the world who we can't, in which we can't do this.
Right. Well, I got to admit, though, your residents, when they were showing the videos of them preparing the corneal grafts, the DMEC grafts, wow, did a beautiful job. I mean, fantastic. It's just, that is truly professional level. They can have a side business setting up a DMEC graft bank. They were fantastic. But no, it's so happy to connect with you. I had a fantastic time at your meeting. I think it's really the way to learn for sure is video. Osher taught us that 40 years ago. Your dad was a pioneer too, 25 years ago, winning his award. Your brother, you, I'm a newcomer to the scene, haven't won any ASCRS festival prizes yet. Maybe I should start asking, but I think that's the way we do it. I mean, we're all visual people. Ophthalmology is a very visual field, and we learn by seeing it. Show me. Don't tell me, show me.
And the power of a dynamic image is tremendous, right? You can learn a lot from a moving image. And as you said, ophthalmology is so easy to do this. It's so easy. We have the eye right here. It's really easy to see and to record what you're doing. And it's very a powerful tool, I think.
Yeah, it's a ton of fun too. I mean, the old days, residents may not know, or young doctors may not know, that the videos in the old days on VHS tape were not even in high def. They're low definition videos. They're like 600 by 480, 640 by 480.
You could barely see any capsular rex. You can probably see the movement of the instrument inside the eye, but you couldn't quite see what was going on. But yeah, again, the quality of the cameras that we have now, they're amazing.
And then the convenience. I mean, the residents pick up your phone and shows you everything in high definition. Anywhere on the planet, wherever you are, you can watch the video. So it's really neat. It's a neat way. I think these videos, especially how they proliferate online, it levels the playing field. It democratizes ophthalmic surgical education. So no matter which country you're in, even if your training program doesn't give you good exposure to this, you can learn it from these videos. You can learn all this. And that's, in fact, I should say, that's how I learned DMEC, by watching other videos. No one came to the operating room and sat next to me and taught me. I watched videos.
Yeah. And again, once you're done with your training, we don't expect the evolution to stop, right? So there will always be a different technique. There will always be a different surgery. There will always be something different that you need to learn as you go. And I think videos are possibly the very best asset for this learning, especially after training.
Right. Now, my only problem I have now is with 2,400 something videos, there's so many videos. And I get kind of figure out,
that's a great problem to have, I think.
Did I already make that video? But yeah, anyway, I want to tell you, we're going to thank you again for sending those two videos. We're going to feature them tomorrow. Is going to be one video, and then the next day, and the Tuesday one is going to be the cataract quiz of why did the DMEC graft partially detach. And I bet you, my smart listeners and viewers, will figure it out. And then on Monday, we'll do the everything everywhere all at once. And then if you guys, my audience, you want to hear and watch these videos that were at the film festival, which are amazing, you got to click on the link down below. Check out that website. I promise you'll learn a lot. And if you definitely want to join us for the ASCRS meeting, the Brazilian cataract refractive meeting next year in May in Sao Paulo, let's do it. We'll all go together.
Absolutely. Well, Uday, once again, thanks a lot for this very kind invitation. I feel very humbled and honored to be a guest of your podcast with so many important names, and many of them people that I consider major mentors of my career, being featured in this podcast before me. So it's a true honor to be here with you. Thanks once again for coming to our meeting here. It's a true pleasure it was a true pleasure to have you here, and it was fun doing this podcast with you.
Oh, my pleasure. You're leaving a huge legacy too. So all these videos, but also the number of residents and fellows you train. I mean, in short work, you're going to have 100, 200, 300 ophthalmologists in the community who learned by you showing them everything. That's like amazing. I encourage you to keep a list of it. I made a list if you go to CataractCoach.com on the website, if you click on About Dr. Devgan, there's a link. I have a list of all the residents I trained over the last 22 years and where they're practicing now. So you got to make that too. That'd be fun. You can keep track of it. And almost like a father, you're so proud of them when they go out and do big things like, yeah, that was my resident. She is doing amazing things now.
Yeah, absolutely. Yeah.
All righty, Bruno. Thank you again for doing the podcast. I want to remind our listeners and viewers, remember, got a new podcast every single week. It's on Amazon, Spotify, Google, Apple, wherever you find your podcast. You're going to find the CataractCoach podcast. And of course, we got a new video every day. We're going to have the next 2 videos be from Bruno. You will really love them, especially the cataract quiz video. Until next time, catch you later.